Hello, everyone. Welcome to the Premium Health Talks. If this is your third session of today, welcome back. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Premium Health Talks is the first international live series that CPBF is hosting in 2021. These educational sessions are in collaboration with the Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, the Canadian Neonatal Network, the European Foundation for the Care of Newborn Infants, EFCNI, and GLANCE, the Global Alliance for Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to empower families of premature babies every step of the way through support and education. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their babies. For this Premium Health Talks, we brought experts from all over the world and Canada, and we'll be diving into topics affecting preemie health, from breastfeeding to parental mental health during the pandemic, from the importance of kangaroo care to the best practice to protect your baby's skin. If you need closed captioning, you can watch it live from our YouTube channel and enable closed captioning on the screen. And I want to thank our sponsors, Medela, Water Wipes, and Prolacta Bioscience. Please use the comment area below your screen to ask and share your perspective and stories. And today we're going to talk about challenges and chances in marginally viable tiny babies. In 2019, a male infant born at 24 weeks of gestation with a birth weight of 268 grams was discharged from hospital. The case gained media attention all over the world, and many questions were raised about how far we can go. The case demonstrated that survival without major complications of a marginally viable tiny infant is possible with minimal handling, family involvement, and breastfeeding, beginning shortly after birth. Dr. Arimitsu hopes this presentation will provide valuable information to physicians, families, and people who are related to tiny babies. Dr. Takeshi Arimitsu is a neonatologist in the Departamento de Pediatría at Keio University Hospital School of Medicine. He has extensive experience in caring for marginally viable small infants, including a girl weighing 265 grams at birth in 2007, the second smallest baby in the world at the time. He bases his medical treatment on being natural and warm-hearted, believing that less medical treatment and more pleasant experiences for the baby should be the main points of consideration. Dr. Arimitsu integrates all possible strengths in treatment, including the patient's family, staff, new medical devices, and the NICU environment to support infants and their future lives. He has authored textbooks on developmental care and peer-reviewed publications on non-invasive functional neuroimaging. He also established the Japanese Organization for NICU Families, the first nationwide parental network for preterm infants in Japan, and has been providing family support as its representative director. I have to pre-record Dr. Arimitsu's session because of our time difference. He's in Tokyo, many hours ahead of us here in Canada. But he told me that you can still send your questions and comments. I will share with him and he will provide answer to you. So here's our recording. Dr. Arimitsu, thank you so much for joining us here today. Such an honor to have you. I really appreciate your time. You're joining us from Tokyo. I know it's morning for you, so I really appreciate the time that you're taking to share your experience and knowledge with us.
Yeah, thank you for having me today, and give me time to talk to you.
Thank you. You can start sharing your screen. We're going to go through your presentation, and we have some questions at the end.
Okay.
Okay, here you go. Okay, you can go on a full slide now. Okay, and you're good to go.
Okay. Thank you for your introduction. I'm Takeshi Arimitsu from the Department of Pediatrics, Keio University School of Medicine. Today, I will talk about the challenges and chances in marginally viable tiny infants by describing my experience as an attending physician for the world's smallest baby boy at the time. Neonatal medicine has dramatically improved the treatment outcomes of low birth weight infants. Although the survival rate of infants weighing less than 1,000 grams is improving worldwide, a high mortality rate and the incidence of severe complications remain common for infants weighing less than 300 grams at birth, particularly in male infants. In recent years, there have been frequent discussions regarding the ethical and social issues involved in treating marginally viable tiny infants. Despite the challenges, reports of such infants surviving are increasing. However, lack of evidence and experience may make physicians reluctant to treat marginally viable tiny infants. Accumulating evidences will advance neonatal medicine and help to address many of the social and ethical issues surrounding their treatment. Progress of neonatal medicine will be achieved through sharing the same purpose with different global stakeholders, including infant families. In 2019, a preterm boy weighing only 268 grams at birth was discharged from Keio University Hospital in Japan. At that time, according to the University of Iowa's Tiniest Babies Registry, he was believed to be the tiniest boy in the world to have been successfully treated without experiencing serious complications. Today, I would like to review my experience as an attending physician by presenting the case of this 268-gram preterm boy. There are 4 important learning points from the successful discharge of this 268-gram boy. First, preterm infants with weights as low as 268 grams can be expected to survive without serious complications. Second, treatments, examinations, and procedures should be minimized. Third, the family should be involved as much as possible. And fourth, the desire to help babies and support their families is a universal one in the world. Of these, most importantly, we need to believe that preterm infants with birth weights as low as 268 grams can be expected to survive. Before 1960, survival of newborns weighing less than 1,000 grams was quite rare. But there is a report of a girl born at 283 grams in 1938 who survived and was discharged from the NICU. This fact certainly suggests that a 268-gram boy can survive. However, it does not mean that all newborns should be treated. The lighter the birth weight, the lower the survival rate and the higher the incidence of long-term sequelae. Careful consideration from various viewpoints, including culture, economy, geography, society, and ethics, is important before treatment is started. In the present case, the family requested treatment, and we were also prepared to providing the necessary medical care. So we started treatments. The next learning point is that treatments, examinations, and procedures should be minimized as much as possible. In other words, avoid unnecessary treatments, examinations, or procedures should be performed. Over-treatment could be fatal to the vulnerable infant's brain because any medical practices have risks such as side effects and complications. So reducing all these factors can prevent brain damage. With this in mind, I would like to review our initial treatment for the present case. His mother was 30 years old and premi-gravid. She had no past medical history and had become pregnant via natural insemination. At 23 weeks of gestation, she was referred to our hospital because of severe fetal growth restriction and was treated with antenatal steroids. The boy was delivered by emergency cesarean section because of interrupted umbilical cord blood flow. There was no umbilical cord coiling or amniotic fluid staining. A boy was intubated with a 2 mm endotracheal tube in OR and admitted to the NICU. The birth weight of the boy was 268 grams, and his Apgar score was 2 and 6. The umbilical artery pH was 7.28. An umbilical vein catheter and peripheral artery line were put in place. The boy's body temperature was 35.8, and his heart rate was 168. His respiratory rate is unknown because he was receiving high-frequency oscillation management. His blood pressure was 32/17, and his SpO2 was 96 with an FiO2 of 0.4. He showed a good general condition, good body movement, good skin color. There were almost no special notes regarding the blood test results, including blood gas. This slide shows the clinical course of the respiratory management. For the respiratory management, HFO was used because of the small lung volume. Caffeine was administered from day 0. Surfactant was administered on day 0 and day 2 because the FiO2 was required to be 0.3 or higher to maintain an SpO2 of 90 or higher. Regarding the circulatory management and sedation, the circulation was good and the fighting was not observed. Therefore, no inotropes or no sedation were administered to minimize treatment. PDA closed after indomethacin administration on day 1. The subsequent clinical course was smooth. We managed his respiratory condition with low MAP and low FiO2. The incubation period was 45 days. Steroids were administered prior to extubation. After extubation, the infant's respiratory condition remained stable with CPAP and high-flow nasal cannula. At the time of discharge, the infant did not need any respiratory support, including home oxygen. We also try to minimize procedures and care. Minimal handling promotes the stability of infants and reduces stress for them. Reducing stress caused by pain has been reported to improve the long-term prognosis. Tracheal suction was performed only when necessary and was not scheduled. Blood tests, such as heel sticks, were avoided as much as possible. This slide compares the number of procedures in the NICUs during the first week of life. Newborns admitted to the NICU can undergo as many as 5 heel sticks and 9 episodes of suctioning. In my case, the 268-gram boy underwent 5 heel sticks and 9 entracheal suctions per day at maximum, and as few as 1 time each during the first week of life. He was successfully treated with minimal handling. The third learning point is that the family should be involved as much as possible. In addition to minimal handling, we encouraged family involvement from the day of birth. Family involvement provides an essential supportive foundation in NICUs and is important for lifelong relationships among family members, facilitates breast milk feeding, reduces stress for both the infants and their families, and promotes the stability and development of the infants. In the present case, from the day of birth, the family began to talk to the boy and to hold him. Oral breast milk application was performed by the family from day 1. One of the most important factors in family involvement is enteral feeding with breast milk. Breast milk can reduce the risk of organ damage, including necrotizing enterocolitis, severe bacterial infection, and lung and brain damage. Breast milk can also enhance family-infant bonding. This video shows a breast milk application session performed by family members. You can see that the boy is reacting to the voice of the family members and the taste of the breast milk. Here, I show the clinical course of nutrition. He started the oral application of breast milk from day 1, increasing the amount of breast milk by 10 to 20 milliliters per kilogram per day. Fortified breast milk was used from day 20 when the infant's breast milk consumption reached 100 milliliters per kilogram per day. We maintained him on a breast milk diet for most of his hospital stay, adding medium-chain triglyceride oil from day 94 to 133 for calorie enrichment. One of the main reasons why the infant's nutritional management was so successful was that his mother provided him with breast milk from early in his life. Thanks in part to breast milk, the infant did not suffer from necrotizing enterocolitis, and we were able to increase enteral feeding with little concern. Later, he was able to drink breast milk on his own, like other babies, and was discharged on February 28, 2019. At the time of discharge, his body weight was 30 to 38 grams. No serious complications occurred, including periventricular leukomalacia, hearing loss, blindness, or bone fractures, apart from retinopathy of prematurity requiring laser treatment. And home oxygen treatment was unnecessary. The boy's mother said, "I can only say how happy I am that he has grown this much." The fourth learning point is that the desire to help babies and support their families is a universal one in the world. Thanks to the support and cooperation of the family and hospital staff, a lively boy with a birth weight of 268 grams was successfully discharged from our hospital. The discharge of this boy was also supported by the development of medicines and medical devices. Successful treatments can be achieved with the advancement in medical technology, including incubator and tracheal tube, ventilators, catheters, vaccines, medications, and so on. It is important to collaborate with different professionals to help and support their infants and their families. After this 268-gram boy was discharged from our hospital, I was interviewed about clinical outcomes of Japan and my experience by people from around the world, including neonatologists, politicians, and business people, families of preterm babies, and global media outlets, including the BBC and CNN. I also became a committee member of the European Foundation for the Care of Newborn Infants, EFCNI. EFCNI is the first pan-European organization and network to represent the interests of preterm and newborn infants and their families. Through my interactions with professionals from around the world, I became convinced that the desire to help babies and support their families is a universal one. I have started to collaborate with different stakeholders around the world to improve the future of their infants and to support their families. This is a picture of another lady who was born at a hospital 20 years ago and weighed 289 grams at birth. She celebrated her 20th birthday in June of 2019. She is currently employed and is an active member of society. Although each person's backgrounds, positions, roles, and values differ, I would like to see a society in which people respect, consider, and support each other. Our warm-heartedness nurtures warm human relationships and leads to a warm society. I hope to unite babies, families, healthcare professionals, businesses, government, and society around the world together with the same purpose. This summarizes today's story. The clinical course of the 268-gram boy presented today is described in detail in this article. I hope that this case report will aid in the progress of neonatal medicine and help to address many of the social and ethical issues surrounding the care of infants. Thank you for listening.
Dr. Arimitsu, thank you so much for sharing your experience with this case. Obviously, this case became well-known all over the world. But I think my first question to you is, 2 years later, how is the baby doing now? You mentioned he had ROP, he had laser treatment. Is there any other developmental delays at this point? Anything that you can share with us?
Okay. So, So the baby introduced today is gradually growing and developing in his own way. And so far, there is no obvious visual impairment. And I think there is a wide range of growth and development in very preterm babies. Some babies grow and develop very quickly, while others do more slowly. What is important is that society as a whole, including medical professionals, should stay close to the families after discharge from the hospital and provide the necessary medical care and social support to the children and families at the proper points. The realization of such a society cannot be done by any one person. Each of us has different values and laws, but we need to support and respect for each other.
Absolutely, and I think the support varies from country to country. I know in Canada varies from province to province. How long do you do follow up with the premature babies in Japan?
We follow up them when at the elementary school, age 7 or 8 years old.
Wow.
At least. It's recommended in Japan.
And all the supports are available for families, from like medical therapies and help for school as well?
Pardon?
Are the supports available for families in terms of therapies, support for the school, so the schools are aware when the babies are premature and they enter the school, so they can provide extra support if needed?
Yes, there are systems to support the preterm infants for medical care, for special medical care and special education. But it is one of the major issues need to be improved in Japan.
Well, I think all over the world, for sure. In Canada, we have a lot of work to do, especially with the education system. But that is incredible that you follow up the babies much longer than any other country. As far as I know, that is incredible. I think we have a lot to learn from you. But Dr. Arimitsu, a question for you, because this case, when the baby was discharged, as you mentioned, it was all over the media. A lot of conversations, how far science can go. And we still know physicians is still, there is some, they hesitate to care for those babies when they are less than 300 grams. So when you look back into your own experience, what are your thoughts around it?
Okay, so in the present case, the baby I introduced today was discharged from our hospital without serious complications, and the bonding between the baby and the family was firmly formed. In recent years, there have been growing number of reports of tiny infants being discharged from the hospital. So with the development of neonatal medicine, more tiny infants can be saved and the risk of complications can be reduced. However, this case does not suggest that all newborns should be treated. So before treating tiny infants, we need to talk with the family and consider medical, cultural, social, and ethical perspectives.
Absolutely. So that was my next question to you. If the parents were involved in the decision making.
Okay. So the parents of the boy were involved in the decision making process. So before the birth, the neonatologist talked to the parents about the clinical outcomes in Japan and at the hospital. So the medical care given to the baby and possible complications after the birth. Their family decided to have a cesarean section and treat the baby. After the birth, we explained the situation to the parents on a daily basis, and they participated in the decision-making process.
This is incredible. It's such a very important conversation. It's a very difficult conversation to have with parents, right? The moment that you're in preterm labor, or you have to deliver the baby in an emergency section, that conversation, I think, stays with the parents for the rest of our lives, because the prognosis, if it's extremely preterm or a very tiny baby, it's very difficult. And I'm glad to hear the parents are present in those decisions. So, but obviously, as we had talked before, the gestation age has a huge influence whether to proceed with care for the tiny babies. So let's talk about the gestational age, because does it change even with those the minimal handling, or having the parental engagement and the oral immunotherapy for the babies based on the gestation age as well? What have you seen?
Okay, so the clinical outcomes of treatment depend on the number of gestational age. So the number of gestational weeks is one of the factors that have the greatest impact on the outcome of treatment for newborns. So if this newborn had been born at 22 weeks, we would have been more delicate. And if he had been born at a larger number of weeks, we might have been a little less nervous. However, no matter what the number of gestational weeks the newborn is born, I believe that minimal handling and breast milk are always useful to reduce stress and complications for newborns and to establish the foundation for family attachment.
Okay, so you talk about obviously breast milk, and we are always promoting breast milk because we know how much better babies do. But we also mentioned that you fortified for this baby. So how many weeks when you start fortifying, and do you think that contributed to the successful discharge of this baby?
Yes. So nutritional management is one of the important factor of neonatal treatment for tiny infants. So in addition to the benefits of breast milk, we need to use the fortified milk to enrich the calorie. So we usually use fortified milk when the infants become 200 grams, but that depends on the infants. We modified our protocol according to their growth charts or the medical conditions, including complications.
Okay, so we saw from different studies that Japan has a 90% survival rate of the tiny babies. So is always the same approach with all the tiny babies in all the hospitals in Japan, or this is particular in your unit?
Yes, so the content and the management which I presented today is partly our special management. So even in Japan, there's a wide variety of treatment protocol for tiny infants, and so we need to exchange information and discuss what is the best choices for tiny infants.
Okay, so you also obviously we talk a lot about parental engagement, and also this varies from country to country, unit to unit. Even sometimes here in Canada, a hospital across the street from each other have different ways to engage parents. So is it common practice in your unit with all parents to be engaged in the care of their babies, or this is a more is a practice for more tiny babies, or this is the way you practice there?
So in a hospital, we try to increase family involvement as much as possible from the early postnatal period. So the specific way of interaction depends on the newborns and their family. So for tiny infants like the boy in this case, we do holding, talk to them, and early administration of breast milk. So in order for anxious families to interact with their infants in NICU with comfort, it is necessary to create a relaxed environment in the NICU for the family. So for this purpose, partitions and reclining chairs may be useful. However, the most important thing is our thoughtfulness to prepare the NICU for families to spend time together. And as you and some each hospital has its rules for family involvement, but I believe we need to increase parental involvement more.
So during this time with the pandemic, we know from units around the world, there are so many restrictions for parents to come and stay with the babies and to still be seen as an essential caregiver, but rather we've been seen as visitors in many places now. How is the situation in your unit? Are parents still coming and involved as they were before, or there's more restrictions as well?
So basically a hospital does not allow family to visit the patients admitted to a hospital. But for preterm babies admitted in NICU, so we try to increase family involvement and allow families to visit our unit to facilitate the family bonding for the development of the infants and in order to support the mental health of parents.
Are both parents allowed to come in at this moment, or will you have the policy of one at a time, or how is the situation there?
So now we are trying to expand the criteria to meet the very preterm infants. So we need to discuss for each case.
Mm-hmm. Okay, Dr. Arimitsu, any final thoughts, any final messages to physicians that are watching us here today that perhaps a little bit on the fence of saving such a tiny babies? I want to leave them with a message today.
Yeah, so thank you. So it's there has a very there's a discussion if we need to treat those tiny infants, but we need to accumulate the evidences for those infants, and we need to discuss about that with families. At the how to say, so when we each time when we think of before we start treatment.
Absolutely. Dr. Arimitsu, thank you so much for joining us here today. It was such a pleasure talking to you and learn from you and your experience in Japan. So thank you so much.
Thank you very much.
And for all of you watching us from YouTube or Facebook, thank you so much for joining us here today. If you missed a talk from today's sessions, you can watch the recordings on our YouTube channel and in a week or so on our website. And I'm going to share our website right here. And I want to thank our sponsors, Medela, Water Wipes, and Prolacta Bioscience for their ongoing support. CPBF is a registered organization, and 100% of all donations received this week will go to our support programs for families. To donate, please go to CanadianPremies.org. Together can create a brighter future to all premature babies and their families. And tomorrow we'll be back on the second day of our Preemie Health Talks with Dr. Sharon Unger from Mount Sinai Hospital. She's going to talk about the human milk and COVID-19, implications for the NICU and milk bank. Also, the lactation consultant team from the Hospital for Sick Children will talk about supporting breastfeeding during the pandemic. So I will see you tomorrow. Thank you so much for joining us here today, and stay well.